a new teaching program. A lot of people ask me that we already running a program called Pediatric Orthopedic Advanced Learning Session, and why we really want a new program. So let me give you a background. Few months back, I was invited to give a talk at the faculty development program on how to teach. And I was trying to search on the net that what is new. And I came across a website that's from Harvard Medical School. And it was a certificate program for training to teach in medicine. So I was really interested that, yes, this is what we are doing, and we need to understand how to teach in a better way. I searched further, and then I saw that the tuition fee for that course is 8,900 US dollar, which comes to 7.5 lakhs rupees, Indian rupees approximately. At that stage, I remembered the words of giant, Professor Benjamin Joseph, that Dhiren, in India, if you want to practice, you cannot afford, or like our patients cannot afford the costly Western technique. And you need to innovate the ideas, and then you have to make it possible so that the treatment is possible to the Indian pockets. And I really did that. And that is what actually this program is. So first of all, what is critical thinking skill? You must be hearing these words like critical thinking, critical thinking. So what is critical thinking? I just would like to say the words of Jeremy Richards, who is a chairman of a medical education committee at the Harvard. And he says that in 2024, it's not sufficient to just have knowledge and a lot of facts. Because now with the Google and lot of books available on the internet, so many lectures available on the net, information is not a problem. We all have a lot of information. But the important thing is like learner needs to able to process the facts and process the fact, synthesize them in the context of the patient's problem, and then apply those facts to create a meaningful, logical, and patient-centered plan of treatment. So that's what the critical thinking is. We need critical thinking in diagnosis and also in the treatment. So in both the important areas, we need critical thinking. The next question is like this should have been taught very early, probably in the school days, or at least from the UG days or from the PG days. Why we are starting this program at this stage? Yes, that's a very valid question. And to give the answer to this, I would give an analogy of a train journey. Suppose we are traveling, and if we get on the wrong train, it's always best to get off at the first station. The longer we take to get off, more expensive will be the return trip. And that's the reason like we are starting this program for the fellows, which is probably a late, but at some point we have to start. Otherwise, like the mistakes or the problem will go on escalating. And these sessions are basically the practice session for the thinkers. And I'm sure that with practice and in due course of time, they will be able to have a helicopter shot like Dhoni. This is going to be the first session, so I would like to lighten the lamp and also seek the blessings of Almighty. And I also seek the support of the friends who have really supported this idea, and many of them are in this meeting also. I also like to thank OrthoTV from a full support. Like on the day when we put the request that we want to start this program, both Dr. Neeraj and Dr. Ashok were say that this is wonderful idea and you should go ahead with that program. So once again, my sincere appreciation for the support of OrthoTV. The today's thinker are Akash Ghosh, Dr. Senthil, Qusur Rabbi from Bangladesh, Muhm Shafeek, Sheenam, Mir, and Devendra from KMC. And we have two subject experts with us, Professor Thomas Palocaren from CMC Vellore and Dr. Venkatadass from Gandga Hospital, Coimbatore. They are the experts and they are going to give their comments after each presentation. If you like the idea and if you want to wear the thinker's hat in future, then please get in touch with me either by email or by WhatsApp. It's ganjwala@gmail.com or my WhatsApp number. So with that, I request the first speaker, Akash, Dr. Akash from Chandigarh to start his presentation. Over to you, Akash.
Yes, sir.
Yes, it's visible.
Yes. So the question given to me to think about was why other growth plates are not affected with conditions like SCFE. So in order to approach this question, I thought it would be easier if we broke it into two parts. First, we should see what are the factors leading to SCFE in the proximal femoral growth plate. And then we have to see whether these factors are present or absent in the other growth plates to understand why they are not affected. So the pathogenesis of slipped capital femoral epiphysis is multifactorial. So there are two things. One is altered physial structure. So these are the factors which affect all the growth plates. Like anything which affects physis structure affects it globally. And this is evidenced by the presence of pre-slip in case of proximal femoral epiphysis. The other thing which is specific to proximal femur is the altering mechanical forces. Specifically, shear force is responsible for slipped capital femoral epiphysis. So this was the initial paper, the earliest paper describing the pathogenesis of slipped capital femoral epiphysis, and they placed a large amount of the blame on obesity. But as we know, obesity is not always present in patients with slipped capital femoral epiphysis. So considering the alterations in physial structure, it has been comprehensively and conclusively proven that with multiple biopsy-based studies, that there is widening of the physis, there is alteration of chondrocyte structures. The chondrocytes are in clusters instead of columns, and there are thinner collagen fibrils. All this leads to weakening of the physis, and they're more prone to slipped capital femoral epiphysis. There is a lot of literature regarding endocrine anomalies. However, this is still controversial. Lots of endocrine anomalies like hypothyroidism, hypogonadism, growth hormone supplementation, steroid therapy, renal osteodystrophy, they have been implicated as to be one of the causative factors for slipped capital femoral epiphysis, but the correlation is still controversial. There is no concrete relation which has been established. Of late, over the last 4 years, a few studies have come which have shown that the leptin levels are significantly higher in patients with slipped capital femoral epiphysis, irrespective of the BMI. Even in thin patients, when there was SCFE, they had high leptin levels. And they also had hyperinsulinemia and high VLDL levels. And this was not necessarily identified as a causative factor, but there was some association which had been established. So coming to the confluence of mechanical factors and biochemical and hormonal factors, obesity is the confluence. So there is altered mechanical stress because of weight and altered growth plates. Altered growth plates are because of a high fat diet. It causes increase in insulin like growth factor 1 and insulin, which accelerates physial growth and leading to widening of physis. And this widened physis is susceptible to slippage. So elevated leptin is coming up as a cause for slipped capital femoral epiphysis, though the relation is not effectively established. It is still a hypothesis, but a much believable hypothesis, if I may say so. So elevated leptin, due to elevated leptin, there is continuous growth, increased IGF-1 levels, and the physis also matures early, but there is rapid growth, which causes widening of the physis and increases the risk. So these are studies which show that enhanced, so they did it in a mouse model, showed that enhanced IGF-1 delivery to the growth plate causes accelerated bone elongation. And one more thing to notice is that obese pediatric trauma patients are more likely to sustain fractures involving the physis than non-obese patients. That means that in obese patients, it is likely that the structure of physis is altered. The association of obesity and SCFE has been repeatedly reported. And then another thing is, it has been shown that mechanical stress is a cause of chondrocyte apoptosis. And chondrocyte apoptosis has been shown in growth plates from children with SCFE. So obesity again causes mechanical stress and leading to chondrocyte apoptosis. Coming to purely mechanical factors, this is a famous study from Chung et al. They did a biomechanical study and found that the forces necessary for causing slippage were found to be within the physiological range of loading that would be generated in overweight children. And this finding was again similarly found in other studies. This is based on computer mathematical modeling. And then another finite element analysis found that the physiological loading was sufficient for causing a slipped capital femoral epiphysis in a weakened physis. The other factors they found were retroversion and varus displacement of the loading vector. Another factor which is repeatedly reported in literature causing altered mechanical stress is acetabular retroversion or relative retroversion. So acetabular retroversion has been found in many patients with SCFE, with many studies giving the range of 47 to 91%. However, in Indian children, the study from Gandga Hospital showed a prevalence of only 25%. So this, again, there is an association, but no established causation. Another factor for altered mechanical stresses is the increased posterior sloping angle. This is another factor which increases the sagittal shear stress on the proximal femoral physis. And one more factor, which is a very interesting factor, which has been highlighted in recent literature, is the anatomy of the epiphyseal tubercle. So there is a peg-like structure present on the epiphysis of the proximal femur. And during adolescence, what happens is that this peg gradually recedes and the periphery of the epiphysis starts cupping. So the epiphysis is like a keystone holding the proximal femoral, locking the proximal femoral epiphysis. The tubercle is like a keystone. And as it gradually recedes, the proximal femur is more prone to slipping from the shear stress. So this is another anatomical basis which is gaining focus in recent literature. So now when we compare proximal femur and other growth plates, endocrine abnormalities, yes, they will affect all of them. Rapid growth phases, like even in case of obesity where there is increased IGF-1, they'll affect all the growth plates. Weight bearing, yes, proximal femur definitely. Other growth plates, maybe yes, maybe no. Lower limb ones are all weight bearing, but they have compressive forces across them and not shear forces. So shear forces, yes, across proximal femur. And other growth plates, yes, there are a few examples which I'll be talking about. And epiphyseal tubercle, that anatomy is very specific to proximal femur, where the epiphysis is like a cup on a peg. And narrowing of perichondrial ring is another factor which uniformly affects all physis. So in case of other joints, what we are seeing is that mechanical stress is missing. The hormonal changes affect all physis, but the mechanical stress is missing. And when we add mechanical stress to the mix, we can see similar problems happening in other joints also. So this is report of one case. It's a case report showing chronic slipping of bilateral distal humeral epiphysis in a gymnast. So you can see that the distal humerus epiphysis has gradually gone into flexion, and this is due to repetitive microtrauma. Similarly, there is a disorder called little leaguer shoulder. It happens in young children who participate in sports involving a lot of throwing. So this also shows that shear stress arising from high torque late in the arm cocking phase is large enough to lead to deformation of proximal humerus epiphyseal cartilage. So again, shear stress coming into play, and shear stress causing similar physeal problems in the proximal humerus epiphysis. And another interesting thing to see is the proximal humerus epiphysis also has a peg on a cup kind of structure. But the thing, what is different here is the peg is on the metaphysis and not on the epiphysis. And this peg is maximum around 11 to 12 years of age. And this also gradually recedes. And this is the age group in which the little leaguer shoulder commonly occurs. So again, in this also you see that in humerus, when there is increased retroversion, there is increased risk of this proximal humerus epiphysiolysis happening. So to conclude, SCFE is multifactorial in origin, and it is a combination of biochemical and mechanical abnormalities. So the biochemical and hormonal abnormalities will affect all growth plates, and other growth plates, when they are subjected to mechanical stress, they can present with SCFE-like disorders. So it is a combination of altered ultrastructure and abnormal mechanical stress. Thank you.
Yeah, thank you, Akash, for a wonderful presentation. No doubt it was a bit long, but still you really brought a very important point into the discussion. So now I request Thomas and Venkat to have their comments. Yeah, Thomas, please.
Yeah, so Akash has obviously done a lot of extensive research, very, very well done. I think he's mentioned all the factors. I think of late, this work on leptin, what caught my attention was the work on leptin and on the epiphyseal tubercle, no? Which he mentioned about being a peg-like factor, which is of recent interest. I think sometimes I think of SCFE as like this cancer thing. No, the latest hypothesis for cancer is that you have susceptible individuals, and then you have a second hit hypothesis. So something like that in my mind. If you have a weakened growth plate during the period of rapid growth, and you have mechanical factors, hormonal factors, shear stresses, and suddenly the ice cream topples over. That's how in my mind, I think I sort of picture it like that. So when you have a combination, one anatomical factor I think he didn't mention was pelvic incidence. So apart from acetabular retroversion, pelvic incidence, if it is lower, and you tend to lean forward and sagittal balance, and your anterior shear forces also act. So that's another anatomical factor they say is a causative thing for these plates to weaken and shear. And because it's a weight-bearing bone, the femur, I think more than the humerus or any other bone, and all these factors line up, and you have a susceptible individual, you'll have SCFE. But it's very well done, Akash. You've done a good job.
Thank you, sir.
Yeah, thank you. We are running a bit late, so now I invite Senthil Kumar to have his presentation, and he's going to speak on how to investigate a child with slip capital femoral epiphysis. This is very practical question because a lot of children have endocrine abnormality, and at what stage we need to investigate and when to treat them before surgery or after surgery is another question. So definitely Senthil Kumar will going to enlighten us on this investigation of a child before surgery. Thank you. Over to you.
Good evening, sir. My question is, how will you investigate a child of SCFE before surgery? So before surgery, I would like to investigate radiological investigations and blood investigations. Radiological investigations to confirm the diagnosis and to evaluate the severity and to plan for the surgery. And blood investigations to rule out the underlying endocrinological conditions, if any. So the endocrinological conditions are common in children who are less than 10 years of age or more than 16 years of age, and whose same age weight is less than 50th percentile. So in those children, they are more, common to have atypical SCFE. So we have to rule out the endocrinological underlying endocrinological causes. So starting with the X-rays, so pelvis with bilateral hip AP and frog-leg lateral view is the most common views taken. So in those view, when we draw in AP view, when we draw a clean line that is parallel to the superior part of the neck, will intersect the part of the lateral epiphysis, wherein case of SCFE, the epiphysis will lie below the line, or it just touches the line. And we have metaphyseal black sign of steel, where the slipped epiphysis will be superimposed over the metaphysis of the neck, which will be seen as a crescent shaped area. So Shyam sign is the inframedial part of the neck will lie medial to the posterior wall of the acetabulum, which will be lost in slip. So these are the morphological changes of the neck in acute. In acute SCFE, there will be no remodeling. In chronic SCFE, where there will be remodeling of the neck, and the epiphysis will be more or less centered over the remodeled neck, causing a banana-shaped neck. This is a morphological change in the acute on chronic SCFE, where there is a prominent step with remodeling of the neck. So south slip angle is measured in AP and lateral views. In AP view and lateral view, the one line is drawn at the base of the epiphysis, and a perpendicular line is drawn to it, and another line along the axis of the shaft, and the angle is measured. Normally it is around 145. In SCFE, it will be reduced. In lateral views, frog-leg lateral views, the normal Southwick angle is around 10 degrees, and in SCFE, it will be increased. And on the SCFE side, if the angle is 60 degree, then the normal 10 degrees will be minus from it, and then the remaining angle is the actual slip angle. So based on this, it is classified into mild slip, where the angle is less than 30, moderate slip is 30 to 60, and severe slip more than 60. The other lateral views were taken, sir, in direct lateral view is indicated when there is an acute slip, or when we suspect a fracture instead of SCFE. So it is taken in supine position with the unaffected limb, hip and knee is flexed at 90 degrees, and the X-ray beam is projected 45 degrees to the hip, while the affected limb is kept in neutral or 15 degrees of internal rotation. A modified billing view can be taken with the affected leg. The knee is flexed to 90 degree, and the femur is externally rotated and kept on a wedge of 25 degree. So based on the ability of the patient to do this, the pelvis can be rotated up to 60 to 70 degrees. So this is the image which we can get. In this view, we can measure the slip angle by drawing 3 lines. First line is drawn along parallel to the anterior cortex of the shaft, and another line is drawn parallel to the anterior neck, and another line joining the base of the epiphysis. And we can take a midpoint between line 1 and 2, and a point at the intersection of the line 1 and 2, and draw a line. And another line is drawn perpendicular to the line B. So the bisector line and bisector line perpendicular line, that is the BP, and the third line, angle between the two is slip angle. So in this view, more than 70 degrees is considered as a significant and slip. So modified done view can be taken. It is done with patient in supine position, hip in 45 degrees of flexion and 20 degrees of abduction with neutral rotation. So CT scan is not routinely indicated. So it is done in chronic healed SCFEs with remodeled neck to measure the actual deformity, and for proper planning of the surgery. So in CT view, in CT scan, you can measure the accurate neck shaft, head neck angle, which is not which is not possible in the X-rays, where the positioning may be difficult, or it is a 2D view, whereas the CT scan is a 3D view where we can measure the exact deformity. So other modalities like MRI and ultrasound are very rarely done. MRI is done in pre-slip and avascular necrosis when we suspect. In ultrasound, we can find out the joint effusion, and the slip can be seen as a step between the epiphysis and the metaphysis. So coming to the blood investigations to rule out the endocrinological causes, there are hypothyroidism. We have to do thyroid function test. The TSH, free T3, free T4 will be free T3 and T4 will be decreased, and TSH will be elevated. Growth hormone deficiency like insulin like growth factor 1, which is decreased. And hypogonadism, we can do in suspected hypogonadism, we can do sex hormone levels, estradiol in females, testosterone in males, luteinizing hormone and follicle stimulating hormone. And in secondary hypoparathyroidism causing renal failure or renal osteodystrophy, we can do calcium, which will be normal or low. Serum phosphate will be elevated because the phosphate excretion will be decreased due to the renal insufficiency. Serum alkaline phosphatase will be elevated due to increased bone turnover. Serum creatinine and blood urea will be elevated, and parathormone will be elevated secondary to the increased phosphate, and vitamin D is decreased due to the renal conversion of active vitamin D. So primary hyperparathyroidism and panhypopituitarism are rare causes. In primary hyperparathyroidism, serum calcium and phosphate will be elevated, the PTH levels will be elevated, and serum alkaline phosphatase also will be elevated. So panhypopituitarism is a very rare endocrinological disorder causing a SCFE. So in which all the stimulating hormones like ACTH, TSH, and growth hormones, luteinizing hormone, follicle stimulating hormone, prolactin, antidiuretic hormone will be decreased, sir. Thank you.
Yeah, excellent, Senthil Kumar. Before we have an expert comment, I would like to ask you, you give a big list. How many investigations actually do you carry out?
So basically, we will do the serum calcium, vitamin D, urea creatinine for the vitamin D deficiency, to rule out vitamin D deficiency and secondary hyperparathyroidism, sir.
Yeah, but like say from like looking at the patient, we cannot rule out other conditions. So unless and until you investigate, how you are going to come to know that whether it's a growth hormone problem or not?
So that is based on the clinical examination, sir. When the patient is found to have the secondary sexual characters are not up to the age, and the signs of hypopituitarism is there, we can do the relevant investigations.
And regarding the radiological investigations, again, you suggested a long list. So how many views do you carry out?
Most AP and frog-leg lateral views are the commonly
done. That's okay, but
if we are not able to do in acute, if we suspect
view,
acute
Dunn's
SCFE,
view, CT scan. So like you describe a lot of things, but how many investigations you actually carry out in a practice?
Sir, in acute SCFE, doing a frog-leg lateral view will exaggerate the pain and it may worsen the slip, sir. So we can take a direct lateral view. The other views are based on the surgeon's preference, sir. So CT scan is done in chronic healed SCFE where there is a severe neck deformity. MRI will be done only when we suspect any avascular necrosis, very rarely, sir. Ultrasound, I've never seen. I just mentioned from the textbooks.
Yeah, Venkat, please, your comments.
Yeah, he made a nice presentation. Pretty much covered whatever is given in the textbooks. It's more from a practice point of view. I think we should give clear indications on when to do what investigation. And of course, you touched upon the blood investigations part, that we don't have to do extensive investigation for ruling out endocrinopathy in every other patient with slip clinical examination. And if clinically we suspect that the child could have any sort of endocrinal problem, then we evaluate. So what we do is we also send to an endocrinologist who is in-house available. So he does the clinical examination of Tanner staging and all that. And if he feels that it is worthwhile doing the investigations, then he gets a list of investigations. Otherwise, the routine bone markers are done for completion's sake, and then we stop with that. Radiologically, I mean, apart from the things which you mentioned, there are recent investigations like bone scans, PET scan. I think Thomas can pitch in with that. They are doing these scans in acute unstable slips to document the vascularity of epiphysis. That is something still the validity of it is not proven in literature, and the evidence is not very strong. But these are the things which are available, and if you're in a situation, an institution where it is available, probably it is not a bad idea to get it documented. But then the management perspective, I'm not sure how much it's going to change as far as unstable slip is concerned.
Yeah, Thomas.
Yeah, I
Yeah.
think Venkat mentioned about bone scan. We do, like he said, we also send to the pediatric endocrinologist. So we do a baseline thyroid, TSH, renal functions, hypopituitary growth hormone, and then send it to the endocrinologist, apart from an X-ray. And like Senthil said, direct lateral for a unstable SCFE. And if it's not an unstable, you can do a cross leg, frog leg lateral. So those are the basic views. We don't do Billings, we don't do CT. But to document blood flow in AVN, we do a bone scan. Because a bone scan literature also says got 100% negative predictive value. That means if it clearly shows there is no vascularity, that means there's definite AVN. It's got 100% negative predictive value, but it is not sensitive. So the sensitivity of bone scan is not good. So there are newer modalities, like last time when we did a webinar, Mr. Madan was saying about the center developing perfusion imaging. So, but they still have not come up with a publication. We are also trying to do something in our center. We're at the moment doing a study. Let's see. It's in the future, but I'm sure something will come up.
Thank you. Let's move on to the third presentation. Qusur, please.
Good evening, everyone. Let me share my screen. So, is it showing?
Yeah. Please go ahead.
So, two questions are given to me. Like one was, what are the different treatment options in case of SCFE diagnosis? What I have found is the mainstay of treatment is in situ fixation or stopping further slippage. In case of stopping further slippage, surgeons usually use two sort of fixation. Either it's in situ fixation, and some surgeons are dealing with close reduction and internal fixation, but they have tried to say that be gentle while doing this close reduction. Along with these two, few surgeon is also practicing arthroscopically doing osteoplasty to get rid of the femoral acetabular impingement. And in case of chronic sleep with a huge bump that is causing FAI, they usually prefer done or modified done by doing safe surgical dislocation, putting the head to its original place and fixing it with its screws. And the second question that was given to me is how to decide the best treatment option for any particular case. To answer this question, actually what we need is to look for these three things. The first thing that we need to find out whether that sleep is an acute sleep or chronic or acute and chronic sleep. To differentiate between acute sleep, chronic sleep is if the symptom is less than 3 weeks old, we can tell it as an acute, we can define it as an acute sleep. More than 3 weeks of symptom, chronic sleep, and maybe the patient is coming late with long-term pain, then suddenly aggravated, and in that case, that may be acute and chronic sleep. The second thing that we need to find out whether that sleep is stable sleep or unstable sleep. In stable sleep, that child will or can stand on his foot or can bear weight over that joint, either along with the help of a crutch or not. And in case of unstable sleep, they can weight bear over that joint. The third thing that we need to keep in mind is what is the type of that sleep. Like the Southeast sleep angle classification, if it's mild sleep, moderate sleep, or severe sleep, that usually varies which treatment they will get. So to find out what is the best treatment option for any particular case, we need to find out, at least we need to go for a good X-ray, preferably through AP view and frog lateral, or as my previous presenter was telling, cross table lateral view, to find out the angle of the sleep. If it's within mild sleep or moderate sleep, then we can easily treat it with in situ fixation by preventing further sleep. And we must follow like a 3-monthly follow-up with X-rays to find out if that fixation was good enough to stop the slippage. The second thing is which type of screw we should use. Previously, we were using titanium in Bangladesh. Then we used distal threaded screws. But recently, after seeing lots of presentation from you, we are using now stainless steel SS screw, preferably 6.5 mm, full threaded. That's how if we need to remove that, some cases that becomes easy. But not likely that this case, in this case, the sleep was very mild, so in situ fixation was quite enough, and that would have done the trick. But in some cases, there will be a bump there along with the facial superior angle. This bump sometimes causes impingement with the acetabulum, and in the long run, that impingement is going to erode that margin of the acetabulum, causing early osteoarthritis. So few of the surgeons are getting with arthroscopically, just removing this bump by arthroscopically osteoplasty. By removing this bump, they may be trying to reduce the chances of osteoarthritis or early osteoarthritis. And in many cases, like when there was a chronic sleep and chronic sleep turns to a huge bump, the preferable treatment in those cases are modified done by sort of like safe surgical dislocation and putting that head over the neck in proper angle and putting screws to hold it. But in those cases, I have less experience. But what I have seen in one of my fellow colleagues' case is they were so aggressive. This was the case. They did modified done, though I think at this stage of my life, only in situ fixation should have been enough for this case. And this was 6 months post-op. It was looking good. Then after 1 year, that is screw broke, and there is a avian area in the superior portion of the head. So what I have got through this case is like it's better to know everything, but treatment, but or the best treatment option for any patient or any child depends on operator or the surgeon itself, whether he's confident enough to do the in situ fixation properly. Because in case of in situ fixation in SCFE, we need to approach it a bit anteriorly and maybe inverts superiorly, because the acetabulum and the head is well inside in its original position, though the neck is directed towards anterolateral and anteromedially. So the screw placement sometimes doesn't go through the lateral border, through the neck to the head. We need to angle the screw differently. And the second thing is whether we are prepared enough to do the arthroscopically osteoplasty, because I don't have any experience about that thing also. And the third thing is modified done is charm. Everyone wants to do modified done, but in the long run, the AVN may happen. Even with good surgeons, AVN rate is very high in case of safe surgical dislocation. Thank you very much.
Yeah, Venkat, your comments?
I think so he pretty much told the concepts of how to decide based on classification, and there are certain things which I accept and certain things which I do not fully accept from what he said. So basically, I look at SCFE as a disease with two different problems. One is the weak physis. On the other side, whenever we see a slip, there is a problem of a change in morphology, what we call as the potential impingement morphology is there. So just doing an in situ fixation is only going to address one side of the problem, which is the weak physis. Our screw is going to stabilize the physis and prevent further slip. So we were thinking that this is enough till maybe like 10 years ago. But now the concept has changed and we are looking at altering the morphology as well. Instead of waiting for the problem to happen, because there is enough evidence even in my personal experience, I've seen that patients coming back with symptomatic femoroacetabular impingement in 10 to 12 years of time. So no more FA is imagination, it is a reality, particularly post subcapital femoral epiphysis, they will have impingement. And to alter the morphology, what you have to do is either, it's basically restoration of the femoral head neck offset. You do it by either doing osteoplasty or a modified done depending upon the severity of the slip. If it is a mild to moderate slip, so I think the next talk will discuss about this more. If it is a mild to moderate slip, you can do an osteoplasty and you don't have to do an arthroscopic osteoplasty. Arthroscopic osteoplasty is what is published in literature, but we have been doing open osteoplasty for so many years. So it's like a simple Smith-Peterson approach. You can open the hip and do an osteoplasty. It's not a difficult procedure. Can be done quite safely without increasing the risk of avascular necrosis, unlike the modified Dunn's procedure. Of course, modified Dunn's procedure is a good one. As you said, it is a technically challenging procedure with a steep learning curve. So it cannot be taken as easily as a light procedure, and you cannot embark on doing it just like that. So you have to learn it, see, and then assess many cases and then start doing it. It is pretty safe technique, but then unfortunately, there are various publications which has showed high AVN rates, but overall AVN rates are comparable. It is not that you cannot or you should not do a modified Dunn's procedure. If you are trained well enough to do it, I think it's a good procedure. It is one of the tools which should be in the armamentarium of treating slip capital femoral epiphysis.
So invariably we should go in all our cases, we should go for open osteoplasty. Like after fixing that in situ fixation, we will go for open osteoplasty.
Yeah, that is something which we are trying to work on. So you have to see whether there is significant impingement. So what do we mean by significant impingement? One of the clinical signs is you check the flexion. You check the internal rotation in 90 degrees of flexion. So if you are not having adequate internal rotation, which means that there is a bony block, there is an impingement which is happening, then you need to do something about it. You can't just leave it, right?
Okay, right. The second thing is like, should you use that close reduction technique? Like, should you try to close reduce that thing?
Yeah. So this is the second thing. So close reduction is
Venkat, for a minute, like, can we wait for the next presentation? Because next presentation is going to cover a lot of
unsolved problems. Yeah,
unsolved problem. Yeah.
Sure.
So let's
We'll go to
have
the
the
next
discussion.
presentation and then we'll
Yeah.
discuss these things.
Thank you.
Yeah, Mohammed, please.
Yes, sir. My screen is visible.
Yes. Yeah.
For this opportunity. I'll be dealing with the unsolved problems of the SCFE. I'm Dr. Shafeek from Christian Medical College, Vellore. So when I started thinking about this topic, I came across one chairman's address published in JAMA 1964. He visited one hospital in another city. There were 17 orthopedicians were doing 17 different types of operation for the SCFE. So he was stated that the doctors was not able to develop an acceptable procedure for treating this condition, which was convincingly better than any other, so that could be generally accepted as a method of treatment. So this problem is since the beginning it is there. So this topic going to be more difficult. And 1960, Watson and Johnson lamented that SCFE is not very happy chapter of the orthopedic history. I would like to start with the definition. I think it needs to be changed because, recent literature has challenged the historical notion, that is the linear shearing forces concept, and it is like a rotational mechanism is proposed. Recent studies suggest rotational mechanism rather than the linear shearing. It was discussed by Akash previously. The epiphyseal tubercle acts as the pivot point for the epiphysis, leading to the posterior displacement. The definition has to be changed. Still, we are following the linear shearing forces concept. And obesity as a risk factor, which is already discussed, which was a strongly studied associated factor. Haversian study stated that the significant factor is elevated serum leptin, regardless of the obesity status. And despite of so much advancement in the medical science and identifying the risk factors, still we have the delay to diagnose the SCFE up to 17 weeks without any change in the last 1 decade. The reason is the most common reason is mostly they were present with the distal thigh pain and knee pain, and lack of awareness of this entity for the primary healthcare providers. How to address this problem? This problem is going to be it can lead to the progression of sleep because of the delay in diagnosis. So we need to do additional awareness programs and education for the non-orthopedic healthcare professionals to address this problem. And the reliability of clean line, we have been using clean line for the diagnosis by using the plain radiograph, but later we came to know that it is not effective enough. For addressing this, Green is modified the clean line by comparing with the contralateral hip. But still, this problem is existing in the case of bilateral slip and atypical SCFE. It is not a good choice for the diagnosis. The controversy between the single versus two screw fixation, everyone knows that the gold standard for the fixation is in situ screw fixation. And various studies have been done to compare the biomechanical single versus double screw. And everyone came to the conclusion that double screw having the more torsional stiffness, more strength. But people are still preferring to the single screw because the risk, numerous as reported like avian chondrolysis, most of the surgeons are still preferring to use the single screw due to the this risk. And Posner survey, which is conducted in 2005, 57% of the people are still preferring the single screws, even in the acute unstable screw, and only 40% employed fixations. Another controversy is whether the threaded or non-threaded fixation. Non-threaded advantage is it can help to continue the neck growth. But when you consider the stability, you have to add multiple pins. It may lead to the multiple complications like AV and chondrolysis and osteoarthritis and all. So we have to take the advantage of screw as well as the pin. For that, the lot of modification happened. That solution is screw that allowed to continue the growth may be superior to the standard screw. Like this, so many screws have been studied, like modified cannulated AOs and uh, hook pins and all studied. And another controversy is open reduction or in situ pinning in the severe unstable slip. Open reduction via surgical hip dislocation increased last decade. And Zebret in his study, he couldn't get any avian. But Obasanis and Sanger study, they have found 22 to 26% of avian rate and overall complication of 37%. They found there is an inverse relationship between the surgeon's volume, how many cases he is attending, and the complication rate, where our Johari et al. Recommended in and later osteochondroplasty. So this is the advantages and disadvantages of the in situ pinning and open reductions. Now the controversy is the chondrolateral prophylactic pinning. The reason of discussion is actually there is a high rate of contralateral slip, which is from 15 to 36%, mostly in the 18 months from the first injury. So we should weigh the benefit against the risk. So Shankar in his study reported up to 6% of complication rate, which include the avian and peri-implant fracture. And there is an excessive consensus that endocrinopathy patients needs to be prophylactically pinned. And Lintel is in his algorithm, he stated that prophylactic pinning should be done children below 13 years because of the linear relation between the skills. The proponents of the contralateral pinning, they are arguing that there is a high incidence of contralateral slip and higher rate of avian and other complication in untreated SCFE. Opponents argue that surgery carries risk in otherwise healthy slip and risk of possible theoretical complications are. And national-wide POSNA survey, which is conducted in 2023, patient with obese patient, younger age, most of the people preferred for prophylactic pinning, and patient with hypothyroidism also most of the patient. But the normal radiographic findings, only 6.6% percentage of patient doctors preferred for fixation, and decreased epiphyseal cupping and posterior slope angle, alpha angle, about 30 to 40% of the doctors preferred for the contralateral. So what to do now? We have to avoid unnecessary fixation and fix only if the risk factors present, that like young age at primary diagnosis, severe slip at primary diagnosis, presence of endocrine disorders, and patient is on any growth hormones. And my professor always used to tell another school of thought regarding the instability, what we know about the Loder's concept of instability, which is based on the ability to walk. And in his study, he showed 47% of avian in unstable SCFE. But what is unstable mechanistically? It is an unstable slip. It's a metaphysis that move independently from the epiphysis. So Zybert is pioneered the use of intraoperative epiphyseal stability as a new benchmark, and he compared it with Loder's concept. So based on the eligibility to walk, the sensitivity of instability is only 39% and specificity is 76%. So Zybers concluded that the current clinical symptoms not accurate to judge the physeal stability. There are some CT characteristics for the preoperative diagnosis of intraoperative stability. And this is a wonderful classification, Mandy classification, which I come across in POSNA's video in 2000 annual proceeding, which was presented by the Jonathan Stoniker. They classified into 4 classifications based on the mobility intraoperatively, and they made a good algorithm for the treatment as well. So it is more appropriate to refer the hip with or without ability to walk as a loader negative and positive rather than historical stable and unstable respectively when using the loader classification system for the avian prediction. And regarding the osteotomy, most of the surgeons accept that osteotomy is more successful method for gaining the anatomical correction, but still they opt for the treatment by subtrochanteric osteotomy because we know the reason this is having the low iatrogenic ischemic rate, but still it failed to restore the abduction power. Maybe patients will be having the trundle number 8 after the surgery, like him, the Inhauser osteotomy. But in the case of the cervical osteotomy, like Dunn's osteotomy, we will achieve a good anatomical reduction, but there is a high risk of iatrogenic osteonecrosis. So there is another confusion regarding the timing of weight bearing. I couldn't find any good studies regarding this, when to wear this, but most of the surgeons prefer to be more careful and delay the weight bearing for several weeks. So when we are not having the any study, we have to look for the expert's opinion. Gordon usually he will allow the weight bearing as tolerated, and he will allow to discontinue the crutches just 2 weeks in a stable SCFE. For unstable SCFE, he used to keep the patient in non-weight bearing for at least 6 weeks. Shankar, partial weight bearing with the crutches for 6 weeks for stable, and unstable touch weight bearing for 8 weeks. Loader, for stable, he can walk at 6 weeks. Or unstable, he used to keep the patient in wheelchair for 6 weeks, then crutches with partial weight bearing next 6 weeks. So based on all these studies, we have to come into conclusion that it's better to keep the patient non-weight bearing at least minimum of 6 weeks, and it's better to restrict their activities until the
You're
final.
not audible, Prof. Can you hear it?
Yes, sir?
Yeah, we are able to hear it. Yeah. Yeah, please continue.
Yes, sir. So another advancement in the SCFE, predicting the avian with the intraoperative perfusion monitoring in unstable SCFE. We usually discuss about the STRADR, which is described the intraoperative perfusion monitoring by using the ICPP probe. But I want to bring another study which is done in our institution far before. I mean, 2011. STRADR was discovered that in 2016. But in our institution, 2011 itself, we have started the intraoperative femoral vascularity monitoring by using the epidural catheter and the anesthesia monitor. So my point is, Ellsworth in his series, he came to the conclusion that intraoperative epiphyseal perfusion monitoring did not reliably predict the development of osteonecrosis. But maybe the reason is the probe which is we are placing maybe a area where the head is receiving the collateral circulation. So the waveform which is demonstrated is not truly representative of perfusion of entire epiphysis. So need to be studied this area more. And many of the Western countries started as thyroid as a routine part of SCFE, routine part of SCFE workup. I don't think it is not in India, many of the places. So there is limited evidence and no formal practice of guidelines. In Nielsen study, he revealed that 30% of incidence of thyroid abnormalities in the SCFE population. So it is better to start to include the thyroid screening as a routine part of our SCFE workup. Another one, does the number of engaged screw thread affect the stability of SCFE? Yes, it is having some values. In Carney's study, all of his deteriorated SCFE had less than 5 screw threads in the epiphysis. In Obasani's study, he studied with the 7.3 AOS. He told it is optimal to keep 2 or 3 in threads in the epiphysis. One more better study by Hussein, he mentions one more better values with more elaborated study. He was telling it is better to obtain stability by using the 4 in the epiphysis. So the presence of 3 or less threads engaging the epiphysis constitutes a risk of epiphyseal slip in the SCFE patient. Next, the controversy or confusion is avian versus time to surgery in unstable SCFE.
Mohammed, how many minutes you have? Like, say you have been given only 3 to 5 minutes, and you are just so. How many slides still remaining?
I can finish in 3.
Yeah, just hurry up, because like the other presenters are suffering because of that.
Sure. So there is a concept of unsafe window defined by the Palocaren between the 24 hours to 7 days, explained by the inflammatory effusion. But cumulative evidence shows that there is no statistically significant association between the time of surgery and lower rate of avian. So for time being, we should adhere to the principle that might decrease the risk of avian. And perpendicular versus oblique screw, we are all using the screw which is having the anterior starting point and which is perpendicular to the epiphysis and physis. But what is the problem with using the laterally based screw which is oblique to the physis, which is not having any significant difference as per the Mercer study? And there is no difference in load to failure in these constructs, no screw-related complications. And surgeons will be more comfortable with the lateral entry point, which is a traditional and technically less demanding. And about the screw thread length, 16 mm, 32 mm, and foot threaded screws. 30 to 16 mm having highest rate of neck failure. It's better to use the 32 mm or full teeth threaded screws. When we are considering about the screw removal, it is better to use stainless steel screw. Is a reasonable option with the hardware removal may be easier. And the scan of subclinical cricket cause SCFE. A prospective study by the Arkader stated that there is no correlation between the low vitamin D and development of SCFE in this subset of patients. Another study, it was conducted in our institution by Madhuri et al. It is a retrospective case series published in JBS. And there is we found that there is a significant difference between the mean value of vitamin D in children with the SCFE compared to the control. And the in situ fixation using radiolucent table versus the fracture table. In Muhammad's study, they reported their lower radiation dose by using the radiolucent table because they compared the cumulative radiation exposure, and maybe it is because of more radiation doses in the lateral view. And Blasier, in his study, found that radiolucent table significantly reduced the operating time. And regarding the screw removal, not much studies about this. There is a debate is still going on. Arguments because of the pediatric age group, we have to remove the implant and adverse effect of the remodeling potential and prominent hardware complications. So we had to look for the expert opinion. Gordon usually not to remove the screws. Shankar also not to remove the screws. Maybe they use and the Loader also not used to remove the screw. They wish to remove in their they come across any kind of complication or when they need to take an MRI. Titanium versus stainless screw. It is everyone knows it is stainless superior to titanium. Titanium is having a strong adherence to bone and the complications like head breakage. So titanium is not an appropriate implant for the SCFE. And a last one, avian is hydrogenic or slip itself. It is remain unclear because the posterior retinacular vessel is supposed to get stretched during the slip. Apex of the deformity right over the lateral epiphyseal vessels. Reduction and pinning have been blamed for decades for this avian development. But avian in acute unstable SCFE can be traumatic, where the torsion and stretching of vessels can be the reason. But in stable SCFE, the iatrogenic reason can be the main culprit because of the bad placement of screws and optic open technique, which is directly hitting the vessels. And concluding here.
Yeah, thank you. May I invite the next speaker because we are really learning very late.
Yeah.
Yeah, the Sheenam is not there, so I request Mir to take over. Yeah, please, Mir. Yeah, Mir, please continue. We are not able to hear you.
Can you unmute yourself, Mir?
Sorry. Share screen. Am I audible, sir?
Yeah, please.
So I'm Dr. Mir Tariq Altaf. I am from Christian Medical College, Vellore. Today, I'm going to discuss about my question, which was, do you ever change in situ pinning technique? If yes, when? If no, why not? So the brief introduction about in situ pinning technique. This is the current gold standard of treatment for mild and most moderate stable slips. There is no attempt at reduction of the slip, and the femoral epiphysis is kept from further slipping by transphysial implant, which can be a screw or any smooth pin or any other implants described earlier. So the screws eventually cause the growth arrest. Then that can lead to LLD. This technique usually does not correct the underlying deformity, and because there is no remodeling, that can lead to FAI, as already mentioned previously by the speakers. So in situ pinning technique, how we do it? We do it on a radiolucent table in a spine position. We perpendicular with split sheets. II will come from the opposite side. We use 7 mm fully threaded cannulated cancel screws with washer, and we mark the trajectory of femoral neck in the AP under II on skin, and then we give 1 to 2 centimeter incision along this line based on the slip severity. If the slip is very severe, the incision will come more anterior. If the slip is mild, the incision will come lateral, and we make the incision. We create a channel down with the Mayo scissors. We try to slit the fascia, and then we put the guide wire down to the bone at the intertrochanteric line. Then the wire is aimed towards the center of the epiphysis and perpendicular to the physis. Then the main issue here is when we put the when we do it on a radiolucent table, and on taking a lateral view, there are chances of wire bending. So we use a cannulated depth gauge to prevent the bending of the wire. So we flex and abduct the hip for frog later, and then we adjust the wire if necessary and advance across the physis under fluoro, stopping short of the subchondral bone. Then we measure the length of the screw. We over drill just across the physis. Then we usually take the image judiciously to ensure guide wire isn't advancing into the joint or pulled out by the drill. So then we insert the screw or the wire. The goal is, as mentioned earlier, 3 to 4 threads across the physis. Then we remove the wire into the screw and then do the approach withdraw technique as previously mentioned. It's we move the hip from internal rotation in varying degrees of flexion to external rotation, and then see the tip apex distance. At any point of time, if we have the doubt, then we have to evaluate post-operatively with a CT scan in that case. So do you ever change the technique? Yes, in valgus SCFE, as you can see in valgus SCFE, the slip is posterolateral. So your entry has to be all the way medial. And in young children also, in severe slip also, I will go in detail in one by one. And valgus SCFE, as I mentioned, the entry point will be medial, and then there is the proximity to the femoral vessels, and that can lead to the injury to the vessels. This is one of the X-rays I'm mentioning here. Then you can see the medial entry point here, and there are ways to avoid it, avoid the vessel injury. Seagal in clinical orthopedic related research in 1996 proposed open pinning through a limited anterior-medial approach. He will see the vessels, he will retract them, and then do the pinning. And in valgus SCFE, usually most of the literature is on mostly case reports only. So Chiok, in his orthopedic research and review in 23, he proposed a sonographic localization of vessel intraop. And there are people who are doing it for in situ pinning just by the routine technique, by using the drill bit with a sleeve and trying to avoid the vessels. But there are reports of vessel injury in valgus SCFE because of the more medial entry point. And then there is in young children, you might leave the growth plate open. The concept of non-fusion technique. So that is an alternative approach in younger children. So it allows the deformity to remodel and prevent any LLD in future. So there are different types of implants, as mentioned by my colleague, like laterally threaded screws. There are medially threaded screws, Hansen's hook pin. There are smooth pins, and screws are usually kept proud laterally to allow growth. But some children are not comfortable with it, with the laterally proud screws. So they have the discomfort. Then orthopediatrics and Synthes have come up with these free gliding telescoping screws. I'm not sure whether anybody is using in India, but we are not using in our institution. We don't have an experience with this screw. So it has a male and a female component, and it allows growth. In severe slips, the in situ pinning is technically difficult, might need to accept a less perfect screw trajectory most of the times. And sometimes the better option is to perform a primary corrective osteotomy and through safe surgical dislocation. And in some cases, if possible, you can do in situ pinning and delay the osteochondroplasty lateral or osteotomy lateral at a later stage. Other modifications which we can do in situ pinning, as mentioned earlier, we can use a fracture table in unstable SCFE. There are proponents of double screw in unstable SCFE to give more stability. And I have seen that in very severe slip, if we put a washer, there is a chance of anterior impingement. So in very severe slips, we can avoid putting a washer. Dr. Venkatadass, he has proposed a custom-made protective sleeve from the X-Fix rod. It is published in IGO in 2021 to avoid that wire bending, guide wire bending. And also there is a one more option. If we are not sure whether we have penetrated the joint, we can make the table tilt and we can inject the dye through the cannulated screw and see whether the dye is going into the joint. And that way we can come to know whether the screw has penetrated the joint. Thank you.
Yeah, thank you. You were very to the point. Yeah, the last, Dr. Devendra.
Devendra, I think you have to
Yeah,
unmute
please, you need to unmute yourself. Devendra, please unmute yourself. Devendra, we can't hear you.
Yes, I think now it's better. Yes, sir.
Yeah, please.
The role of advanced imaging in SCFE. So, so sorry. So the what are the advanced imaging modalities in SCFE? So CT scan, MRI, bone scan, and ultrasound. So generally, radiographs are sufficient for evaluation of majority of the children with SCFE, and many of the surgeons do not even do not use the other modalities. But generally, if these additional modalities are useful, especially for better appreciating the pathoanatomy, and when we can case of pre-slip osteonecrosis of the femoral head, fusion, whether to check the fusion of the physis, and if there is any articular cartilage damage, this can be better made out by these advanced imaging modalities. So if we come to CT scan with axial and sagittal sections and 3D reconstruction helps to understand the post-slip deformity better. Although we can make out these various parameters in an X-ray also, we can better delineate the pathoanatomy, the degree of slip, the head neck angle, the amount of retroversion, the residual deformity, and the presence of the callus. And also the CT scan is also used is to confirm the closure of the physis. and to rule out any penetration by the metal wear after surgery. So you can see on the picture here, in case of a chronic sticky, you can see there is a spot weld which is probably giving some stability to the slip. Whereas on the right side picture, it is an acute slip where there is no or little stability. So the role of MRI. MRI is useful to assess equifocal cases of SCFE in the pre-slip stage. So in the X-rays, we can see that the X-rays are relatively, we could say that on the right side is normal, but there is narrow edema on MRI and joint effusion on which could not be made out on the plain X-ray. So this is another image on the left side. We can see the growth plate has increased in size, and which indicates the pre-slip condition. So this is a case of in which the right side has already been strained. We can see that the fibrosis has on the left side has increased in size, which is indicating a pre-slip condition. So MRI also assists the avascular necrosis of the femoral head in post-CT, the location, the extent, and the distribution of the avascular necrosis. So as Sir pointed out, perfusion scan is also useful for assessing the vascularity of the femoral head, either that is before and after the surgery also. So this is a this is an image of a still image of a sequence of MRI, which shows bone marrow edema, which is maybe an early sign of AVM. So we can also assess the cartilage damage in case of a chronic slip. You can see that the acetabular margin has been damaged in the left because of the bump, which you can see on the X-ray, and that has caused the acetabular cartilage damage, which can be seen on the MRI. Now, what the other newer modality which is coming is the degenerate scan. It is extensively used mostly in the knee joint, but it's also nowadays it's used in CT, in which basically we inject a negative dye, negative charge dye, either intraarticularly or intravenously, and it repels the glycosaminoglycan. And if the glycosaminoglycans are intact, and then there is no there is natural repulsion of the dye. But if there is no decrease in the glycosaminoglycan content of the cartilage, the dye tends to home into the damaged area. So the other modality, the bone scan has a role in assessing femoral head vascularity. It is instrumental in when there are metal artifact disturbances. As Sir said, there has a 100% negative predictive value, but it has low sensitivity. So ultrasonography is less used, and it is subjective. It depends upon we need a good radiologist or sonologist for this, and it can help assess the stability of the slip. In acute slips, we can classically see joint effusion, and there would be a step off. And radiologically, a 2 mm step off compared to the opposite side, or a displacement of greater than 6 mm on the lateral side, absolute displacement would be diagnostic of a slip. But as I said, that this has very limited indication or application nowadays. And these are my references. Thank you.
Yeah, thank you. Yeah, Venkat, would you like to comments, and then we can have a comment by.
I think overall this was a good session. All of the people who presented then done a good job by doing good literature search and putting their mind into it and what to present. So in that sense, I think they have done their homework well, and I think it has kindled some thought process about what are all the current controversies we are facing in slip cap femoral epiphysis. To sum it up, I think the longest presentation was about the unsolved problems in slip capital femoral epiphysis. I would say that we do not have so much of unsolved problems. Fortunately, there are controversies. There is a difference between unsolved problems and controversies. What I want you people to understand is principles never change. Concepts or techniques on doing things might change. So, for instance, the principle of stabilizing the epiphysis does not change. No matter what, it is a weak physis, it needs to be stabilized. That is the principle. Whether to use a titanium screw or a K-wire or a growing screw, all that is like technical difficulties using radiolucent table. So the principles never change. In that sense, the principles still are clearly laid out, except very few areas where we still do not know when to do an osteoplasty, when should we do it or not, whether it should be aggressive or not. And I think apart from that, most of the principles are clearly laid out already. It's a disease which has two components, as I already told, and both needs to be addressed. The second part of it, when it is symptomatic, you can address, or it. So the evidence is not still clear about that aspect. I mean, I think we cannot. We can go on discussing about SCFE for hours together, but that is not the idea. If Thomas wants to say something, I think.
Yeah, Thomas.
Yeah, I think Venkat put it all quite well. I must say, we don't give Shafeek a wide berth. We only give him a very specific thing. Otherwise, he'll have so much of information that even my head will burst. So we always give Shafeek a very, very limited topic. If you give him a wide topic, this is what will happen. Anyway, what Venkat said is very true. So the principles are very, very, very straightforward. If there is a slip, you stabilize it. Second principle is to prevent deformity. Third principle is to minimize complications like avian and chondrolysis. For the beginner, in situ pinning is safe. It's still the classical method. And even in centers abroad, surgical dislocation are only done in referral centers, and it's got a steep learning curve. So somebody like Dr. Prasad or Venkat, or you should go and learn under them. Not chuma see one video and do one. It's not that simple. Even in the best of hands, 20 to 30% avian rates are there. Because as Mr. Madan said, even in Ganges, he said everything was not unstable. So even in a series where there's no avian, Mr. Madan was saying in a webinar that actually there's a mix of stable and unstable, and rates of unstable also in most people's hands. If guns or surgical dislocation is 20 to 30%. And in chronic SCFE where there's no avian, you should not, as a beginner, ever try doing iatrogenically caused avian. So it's better to be safe, in my opinion. And as a beginner, because you're not in a high volume center, even in Boston, where Millis, somebody like Young Joachim has to be in the theater for you to do a surgical lip dislocation. So in India, it's not regulated. So my fervent appeal to people are to be safe, not to listen to your Hippocratic oath. First, do no harm. If you're good, if you learn under somebody, then you know how to do surgical dislocation without complications, please go ahead. But there's a steep learning curve. That's all I have to say. If Prasad is there, I think I saw Prasad's name. Maybe he should be in.
Yeah, Prasad was here. But like say, we will involve him in.
For the youngsters, having learned about this, I think the idea of this whole session is that you should come out with some research questions. Think about the lacunae existing in the literature, and think about some research questions so that you think that it is worthwhile not doing, and you need to find answers. So that is I think the idea of the critical thinking session. So I think all of you should come out with one research question at least.
Yeah, thank you, Venkat. That's really a good suggestion. And one of the aim of this session is, which we will try to implement next time, is like when it comes to presentation, again, you really need to identify that what are important points and
Yes.
what points you can skip due to lack of time. So that is also going to be the next time we are trying to enforce that exercise also. So thank you very much, the thinkers as well as the experts, for sharing your views. And I'm sure that this is a beginning, and with due course of time, our thinking will also improve, and this will definitely help us in a long run. So with that, once again, thank you everyone, and thank you OrthoTV.
Thank you, sir. Thank you.
Thank
Thanks for the
you.
opportunity.
Bye.
Good night, everybody.
Good night.
Good night.